we can go ahead and start. We're going to give about 2 minutes for folks to trickle in because I see some folks lingering in the lobby, so we'll get started about 2 minutes past. Yeah. Great. Thank you so much.
We'll put it right here between us. Pointing towards you. Because that's what we did. Yeah, why aren't they doing that? I did that all the time. That works. When I was at Columbia River, like if I had clients who were like, someone, he gouged out his eye one time when he was really sick. He was really worried about what would happen again. Bro, got the solution for you. Yeah.
Okay. Thank you, everyone, for joining. My name is Sarah Rayner. I'm a research project manager at the OHSU PSU School of Public Health. I have the pleasure in my role of working with all of these folks and more. We have IMPACTS grantees. That stands for Improving People's Access to Community-Based Treatment, Support, and Services. This is an Oregon-based program. It's administered by the Oregon Criminal Justice Commission. And we have a representative from the Oregon Criminal Justice Commission right at the end of our panel, Will, who's going to kick us off today by sharing some details about where IMPACTS came from, who the target population is, and provide some context before we hear about the great work that the grantees are doing on the ground in their communities. Will, I'll turn it to you.
Thank you, Sarah. Can everybody hear me okay? Perfect. My name is William Ash Houchin. I'm a research analyst at the Oregon Criminal Justice Commission, and I'm so pleased to see you today because that tells me that you're just as interested in the intersection of behavioral health and criminal justice like we are. Just a bit of background about the IMPACTS grant program. In 2019, the Oregon legislature passed Senate Bill 973, which recognized the shortage of mental health capacity and resources across the state, particularly for those cases where people have both either mental health or substance use or both, just behavioral health conditions, that leads to their involvement with the criminal justice system or other emergency services such as the Oregon State Hospital or local emergency departments. And so as a result, as we've heard, the Improving People's Access to Community-Based Treatment Supports and Services, or IMPACTS grant, was formed as a result of that. And then, if you remember the time, this is about 2019, shortly after that, of course, we entered a global pandemic, which of course exacerbated the behavioral health needs in the state, as well as taxed the capacity in a way that we had not seen in some time. And so the truth is that many communities in Oregon lack either the structure or the capacity or the resources necessary to implement these community-based treatments and supports. And so the purpose of the IMPACTS grant is to provide counties as well as Oregon's federally recognized Indian tribes with grants to implement these programs. And so we know that IMPACTS helps fill critical needs in communities with local programs aimed at meeting clients where they are and providing them with low barrier services, as well as moving them more towards stability and recovery in the community versus with an institutional placement. And so just to mention a little bit more about the primary goals of IMPACTS, there are two. The first is to establish evidence-based and tribal-based programs that are operated by Oregon's counties and federally recognized Indian tribes that provide supports and services to a target population within that community. And then a second, but just as important, goal is to reduce the frequency with which persons served by the program are involved with the criminal justice system or other emergency services such as emergency departments or the Oregon State Hospital. And so just a bit about the key players. I work for the Criminal Justice Commission in Oregon. We are the administering agency for this grant. We also provide staff support to the Grant Review Committee for this grant. We do this in consultation with the Oregon Health Authority. As we heard this morning from Judge Waller, these things work best when we can break down those silos. And so, although we are a public safety agency, we do consult regularly with the Oregon Health Authority. As I mentioned, we have a grant review committee that is co-chaired by the executive director of the Oregon Criminal Justice Commission, as well as the interim behavioral health director of the Oregon Health Authority. And some members of this committee are appointed by the governor, others are written into the statute, and they are the primary decision makers in terms of where funding goes, programmatic shifts, anything like that. But that's not all. We also have research partners, one of which we've already heard from today. We have the Oregon Health and Science University, Portland State University School of Public Health. That is the Waddell Research Group. Sarah is a member of that. And then we also work with the Oregon Health and Science University Center for Health Systems Effectiveness to do a more statewide sort of evaluation, whereas we get a lot of local support from the Waddell Research Group. And so just a bit more broad overview of the impacts. Eligible applicants include Oregon's counties as well as the federally recognized Indian tribal governments, and they can work together. That's something else we've heard that has becoming a best practice. And so $10 million was originally appropriated for the 2019 through 2021 biennium, and then a second $10 million of that was for the 2021 to 2023 biennium. So the current grantees have funding through June 30th of 2024. Just a bit more about the target population. So as I've mentioned, in Oregon, we like to call them friendly faces. You may have heard them as frequent flyers or people who high resource utilizers. Whichever term you wish to use, these are people who are disproportionately using these expensive resources. And sometimes this is not, oh, I went to the emergency room instead of going to urgent care for my cough. This is people using, for example, an emergency department for shelter and using it for regular meals. And so that time and those resources could potentially be better spent elsewhere. And so they have one or more behavioral health conditions. That's a requirement to be in the target population. And grantees, we think importantly, are able to define these based on their local community needs. And so in some cases, that may be more shifted towards the emergency department. In some cases, it's more on the public safety, law enforcement side. But regardless, what we know is that our impacts grantees, they represent 11 counties and 5 federally recognized tribal governments. And we're so pleased that many of them are here today to share about their programs. So one more thing on your way out today, if you're interested, we have business cards here for both Casey, who is the program manager, she just waved for us, as well as myself. We have some just one-page handouts if you're interested in learning more. And then if you're super interested in learning more, we have our most recent report that we submitted to the legislature in January. We have just a few of these, but we can also provide it to you in a PDF. So with that, I'll pass it back to Sarah. Thank you.
Thank you, Will. So today we have grantees represented from 5 sites. We actually have a second panel following this with grantees from 3 additional sites. So we welcome you to continue the conversation afterwards. To get started, to kind of put into context what Will was sharing about, where did this program come from, who is the target population, what are the primary goals, let's turn it to the grantees and hear from each of them just about a 5 to 10 minute tops overview of what your program looks like on the ground. So we're gonna start down at the end of the line with Sue Goldberg. And Sue, please let us know what grantee site you represent, and go ahead.
Thank you. Thank you, Sarah. And no magic tricks this afternoon?
Not today.
All right. Well, I'm from Douglas County, and Douglas County is in southwestern Oregon. Its largest city is Roseburg with a population of 25,000. Roseburg straddles the I-5 corridor, and it's about 2 hours north of the California border. In 2020, Douglas County was awarded funding from the Impacts Grant, which we can attribute its success to the fantastic collaboration we have with our community stakeholders. This includes the Sheriff's Department, the City Police Department, Parole and Probation, Mental Health Court, the local community hospital, Community Mental Health Agency, the local SUD agency, the Chadwick Clubhouse, and many others. It also includes the Coordinated Care Organization supporting the Medicaid population in Douglas County, which represents about 40% of the total population. That is who I work for. the coordinated care organization in Douglas County, Umpqua Health Alliance. As Will said, the program was based on the grant initiative to identify and engage justice-involved individuals with behavioral health concerns, specifically subjects with 4 or more incarcerations per calendar year. Together, we track both jail and healthcare utilization, and I think that's a great partnership. We'll go into detail here. So working with the jail in 2019, we identified individuals with 4 or more bookings who were covered by Medicaid through our CCO. This became our initial impacts cohort of 247 subjects. Each January, the jail would provide an Excel file of individuals booked 4 or more times the previous calendar year, and we would identify new cohort members. At the end of 2022, 333 people, of which approximately 150 are active in our community. In 2021, the grant funded a patient navigator in the emergency room of our local community hospital to intercept and potentially engage subjects for intensive care coordination, or ICC. Grant funding allowed Douglas County to construct the first sobering center in our area. It's located next door to the SUD Treatment Center. Individuals are brought in by law enforcement officers through a secure gate to the sobering center, where they can stay up to 23 hours. During this time, options to enter detox and residential treatment are discussed with the individual, and if they are willing, it's only a few steps away to the detox intake. This arrangement has worked well to engage individuals and has reduced the burden on law enforcement and our local hospital. We made a huge breakthrough in 2022, and I can't help but smile about this. We negotiated a jail data use agreement, allowing us, the CCO, to receive daily bookings and releases from the local county jail. In April of 2022, our community mental health agency, using grant funds, hired staffing to perform jail in-reach for impact subjects while in custody. So that's a huge step. This has been the most successful process for engaging individuals in ICC and has demonstrated success. They documented 72 jail in-reaches just from October through December of 2022, when the jail data use agreement became live, and have 121 jail in-reaches thus far in 2023. From that, we've now developed a monitoring dashboard that allows for identification of individuals who have 2 or 3 bookings. So now we can use it as an intervention to proactively manage these individuals before they reach the 4 or more threshold. And so that's working real well as well. With these 2 components, we've seen a major improvements in engaging individuals in intensive care coordination upon release from jail. And here's how it works. The ICC team logs into our daily dashboard from the jail. And mind you, it's updated every night, so it's fresh data every day. And they can quickly identify the impacts subjects in custody, and then the ICC team arranges jail in-reach with these individuals to begin the conversations to engage subjects in services. On any given day, there's roughly 25 of our impact subjects in the county jail. Previously, our ICC team would do outreach in the community at the camps and provide items such as t-shirts, socks, sleeping bags, tents. People soon became comfortable with the team and would oftentimes approach them. However, we found the jail in-reach program far more effective in engaging subjects in supports and services. Individuals are more willing to consider programs to reduce recidivism while incarcerated versus outreach attempts in the community or the ED. This has resulted in several successes. There was a woman my age, and I'm no young chicken, so, who had a long-term pattern of homelessness, oftentimes intoxicated in public. She lived in a camp near a local grocery store. She had 31 jail bookings and 85 emergency room visits. She had untreated behavioral health issues. After release from jail in mid-21, the subject connected the ICC team, who found an effective way to engage services and achieve and maintain stability. Basically, they asked her, what as a human being do you need to become stable? They provided sleeping bag, clothing, bag, and eventually the individual began seeking them out. The ICC team then engaged the individual in intensive mental health services, SUD treatment programs, medical care, and skills training. By fall, the subject moved into transitional housing, then to Section 8 housing, and just this spring, in April, their very first apartment. The individual has completed SUD treatment and has now stabilized and volunteers at a local church. We've calculated the cost avoidance for this one individual of $36,000 in emergency room costs and $15,000 of jail costs for a total of $52,000. And the last success story I have is another individual had 13 jail bookings, 119 emergency room visits, 6 inpatient stays, and 30 emergency transports over the past 3 years. The individual was engaged with the ICC team, who soon identified the need for a more stable living environment and successfully transitioned the individual to an adult mental health foster home. That was paid for by the Impacts Grant. The individual's ED visits went from 46 in 2021 to 1 in 2022. Cost avoidance for this one individual is $89,000. So you can see the impact that the Impacts Grant, pun intended, has done, and it's because of our strong community collaboration. We are changing people's lives, and we're reducing recidivism in Douglas County.
You and I together. So my name is Lori Lager, and I am the Executive Director of Reconnections Counseling, and we are in Lincoln County. And we partnered with the local Sheriff's Department, and we started what's called LEADS, Law Enforcement Assisted Diversion. Jamel is actually the LEADS navigator for Lincoln County. She is essentially on call 24 hours a day. How LEADS works is that it's identified, the police officers identify people that have social determinants of health crimes. We're not talking about major crimes. We're talking about trespassing. We're talking about theft for food. We're talking about homelessness issues. I mean, things that are the police are rolling out on, but it is not a crime. It's something that the navigator helps with. So Jamel gets called pretty much all day long, and she responds, and she's going to talk to you a little bit about some of the people that she responds to, and her job is to do a strengths and needs assessment. She sits down with them, she looks at what their strengths are, what their needs are, and then she helps them navigate systems in our community. And we have found that she is with people probably in the first week, a good 8 to 10 hours a day. And then as she helps them navigate services and connect to the community and connect to community services, then she can essentially move on to the next person. Some of the things that the Impact Grant pays for is we actually have a duplex. LEADS rents a duplex in Newport. So when we first started doing responding to LEADS calls, we would put people up in a motel so Jamel could find them. And we were utilizing a lot of money because in the summer in Newport, motels are expensive. And so we rented a duplex, and so we actually, if we have room, we put people up in the duplex, and then they can stay there as long as they need to until we can find them housing. And we actually have 2 men living in our duplex right now, and they've been there a little while, but both of them, one is number 4 on the waiting list for an apartment, and the other one is waiting for an adult foster home. And they wouldn't have any other options. So we've utilized the money a little bit differently. We go out into the field. Jamel responds with, as like a co-response with police. And then a lot of times she'll take them and put them in her car, and make a decision based on her strength and needs assessment on what their exact immediate needs are. And then she spends as much time with them as she can to address, essentially all of their social determinants of health issues that are identified. When we originally started the impacts, we put down on our grant that she was going to respond to 2 people a month. How many people do you respond to a month, Jamel?
5 to 6, right?
Yeah, 5 to 6 people a month that she's responding to. And her and I talk a lot about how, a lot of times the counselors at Reconnections have 40 to 45 clients. Jamel works with maybe 2 to 3 at a time because they are taking up more than 40 hours of her week. She literally focuses on them and focuses on what their needs are and really works with trying to help them meet their needs. So Jamel's going to talk to you a little bit about, we have a couple that we're working with. So not only, don't forget that you're a doula too.
Yeah.
And so go ahead.
Yeah, so as she said, I'm Jamel Villarreal. I'm a peer mentor. So I have lived experience pretty much with mental health, drug addiction, and I have compassion, and I just want to help the people that I was in the same position that they were in. And so I think it helps, pun intended, impact the people, the community in need is somebody that understands what they're going through. So I come there and I meet them, and so we have a couple, 20 years old, pregnant, almost 8 months pregnant, never had prenatal care. They're both DD services, on a Medicaid, and they are drug addicts, and they had nothing or anyone. And so I was called out, and because I was called out, because the police officer determined this is somebody that this could benefit, that, leads could benefit them. And I went out there, we got their insurance back on, we got them prenatal care, we got them into Coastal Rising Phoenix, which is a shelter located in Lincoln City that we partner with. And so we were able to get them in housing and out of a bad situation. And I think that it took us like maybe 30 days, so it was kind of challenging, but it was more than anything that they have been able to do. And so that's the impact that we've been able to do is, help this baby, this unborn child to come into the world with the prenatal care that they need, also support them and also get them services that they need, may it be drug and alcohol or anything like that. I'm getting that connection for them.
So one of the things that Jamel left out is that, she's not tooting her own horn, but she's a doula as well. So not only are you a peer mentor, you're a certified recovery mentor, and she's a doula. So in our Nurture, we connected them with Nurture Oregon, which is a program that's in 5 counties in Oregon. So they not only have a substance abuse counselor, they are a turnkey. They actually went into one of the turnkeys. They have a doula, which is Jamel. And she has been to multiple doctor's appointments, and now we're actually, because they are in need of DD services, we're actually we're connecting them back with their family in Idaho. So when she has the baby, she will have natural supports to help her take care of a baby. And she's, like I said, she's 20, this is her first baby. So we're actually, Jamel really worked on getting them stabilized, and then now we're actually working on moving them back into their community in Idaho, and we're actually, the Impacts Grant's going to pay for them. We're putting them on the bus on Monday, and there is family on the other end that is gonna pick them up. And we're working on getting medical care back in Idaho, so when she has that baby in the next 30 days, she has that baby with family around her. So this all started because the police officer called Jamel to that motel room, and instead of taking them to jail because they wouldn't leave because they couldn't pay for the motel room anymore and they had nowhere to go, then, that's where we come in, and we connect them with those services, and we paid for the motel room for a little while until we could actually get them into a turnkey. And so we actually, Impacts has had huge, huge changing mechanisms for people in Lincoln County that, would historically have been just taken to jail. And so we're big Impacts people as well, and we just appreciate all of the support that the CJC has given us. Thank you.
Thank you.
Hi, I'm Olivia McClellan, and this is Jeremy Jeller, and we're from Lane County Behavioral Health. And our Impact Strat is our FIT team. You might have heard a few people mention it, so we're super stoked on it. Our FIT team, which is Forensic Intensive Treatment Team, was actually born out of a systems survey that our Mental Health Summit, which is a summit that we have monthly with our community partners, law enforcement, the courts, community housing, behavioral health, addictions. There's a whole host of people that we come together once a month and from across the county and sort of meet and talk about what's going well, what's not going well. So we've had this meeting going on for several years. And as a part of that, we did a system survey, and the system really talked about, it was addressing gaps that we saw. And crisis services, like many counties, Lane County was experiencing significant crisis service gaps. And so for those of you who aren't familiar with Lane County, we go from Florence to Oak Ridge, so we go from the Cascades to the coast. We're not necessarily the most populous county, but we have a little bit of land mass between, and a variety of services. So we have sort of this hub in the middle that's along I-5 that is metropolitan, and then we have our rural communities on the outside of that. So how do you provide services, create better crisis system services for folks that have a variety of needs across a large geographical area? And that part of it was, we talked about a stabilization center, which everybody's, I feel like that's the new it thing, right, is the stabilization centers. They're really important and they're valuable, and they're really hard to put together. So that's a process that's going on, and that's way out in the distant future, and everybody came together and said, okay, we need something in between there. We need something right now to deal with what's going on, and that's when the FIT team was born. It's based off of a couple of different programs. There's a model in New York that's very similar to what we do, and then there's another thing called the Yellow Line Project, and so that's more of a diversion program. But when we came together as a community and started looking at what we wanted to have available, those are the two programs that we sort of tapped into, and then we got creative around what are our needs and how do we meet the needs of our specific community based on that. It took us about 1 year prior to applying to the grant to sort of come together in committee work, lots and lots of committee work, subcommittee work. Everybody had a voice at the table. That's why it took us a little bit longer, is because, competing interests. We all wanted to help the same group of people, but how we were going to do it looked very different depending upon where you were situated and what resources you had available to you. So we had we had policing, we had multi-agencies, Sheriff's Department, about 4 jurisdictions that were also represented, probation and parole, 2 jails that were represented, staff from the circuit court, a couple of muni courts that we have, and then all of our housing community partners. We had folks, so we all came together and said, okay, how do we help these folks that we're all seeing? They're all touching us in different ways. And we came up with this creative idea. And I'm going to hand it over to Jeremy to talk about what we do.
So our team is it's comprised of, we've got 2 case managers in the Lane County Jail, 2 therapists in our clinic, me, a case manager, and 2 peers, and a support staff who's basically our air traffic controller. So she's essentially basically our daily dispatcher. And then we have a part-time prescriber. And so our team functions mostly in the streets and in the community, so we're about 95% outside of our clinic setting, although we have a little hub office that people can come to. We do try to do some clinic-based stuff, so we have drop-in hours for therapists, so people can come and drop in from 9 to 11 and 3 to 5, Monday through Friday. And that's for the folks that just are non-linear, can't keep an appointment. We still want them to have a place to go to if we can't find them on the streets. Around 9 a.m., our team gets together and maps the day, so we look at all the screenings that have come in through the jail. We average, I'd say, anywhere between like 3 to 6 screening referrals within the jail, and anywhere between 5 and 10 in the community. So we've got about 10 to 15-ish referrals to look at and try to figure out a smart and tactical way to outreach everybody. And then we just map it all out and figure out within mostly the 2 metro areas of downtown Eugene and Springfield, but then the surrounding areas where we're going to go. And then we just go looking for the people. We have our frequent flyers, people who we know really well, who are fully enrolled. And so for those folks, they can get everything that we offer, which is therapy, case management, peer support, prescribing, groups, and and some limited funding for support items like clothing and other things. One of the, I think, really interesting things about our team is that we have the ability to kind of navigate in and out of systems. So a number of us have full jail background clearance, so we can go into the jail, right, cell side and consult with people. The staff are doing work on the actual streets, and it's kind of awkward with HIPAA. We know we try to be respectful, but we can, be doing therapy and things and interventions right there on the streets. My staff have access to me, so I can be doing, if I'm not able to get there, just curbside consulting through MS Teams or something, some way to just talk. Our prescriber has the ability for our fully open people to go out and do prescribing on the street, and then our peers can then take the person to the pharmacy. So we've got this really dynamic kind of way of replicating the best we can the same level of care somebody get in an outpatient setting on the streets. And we really believe in that everybody should have access. And a lot of the people we see just will never step foot inside of a government clinic ever. So in our community, I thought I knew what was up. 20 years in the field, I'm going on 11 years of behavioral health. What I didn't realize that there was levels to this game. There's the outpatient, there's all these forensic systems, and there's people we were seeing kind of that were having a hard time. And there's about 4 more levels below that, and that's who we're serving. And the people who have been banned from every clinic, every setting, every homeless shelter, they know they're notorious people for the most part, and people have given up on. And so one of our missions as a team is just not to give up on them. And so we just keep repeatedly showing up. At some point I joke around like I'm a used car salesman, because I'm walking up to people, that are either high on fentanyl or meth typically in the community, and we're just trying to convince them to just engage with us. And we just keep coming back. Occasionally we'll back off if they're truly are just like, I don't want nothing to do with y'all, get away from me. We're like, okay, fair enough, here's our card. And people come back. It might be the 9th time we try to outreach them. The jail staff are amazing partners, and they know all these folks as well. And so they're working with us continuously to, give us heads up on people. And I think, I'm trying to think what else would be really important. Just like.
I just wanted to piggyback something you said, and that you had mentioned down before, is that as a part of that year-long process, before we were able to get our program up and running, was we spent hundreds of hours getting everything in order so that we could have shared data. And that has been absolutely worth absolutely everything. Being able to know who's in the jail, who's in the hospital, who's at different sites. We have access to all of that information through MOUs and government, intergovernmental agreements. So that has been, if you're all thinking about doing something like that, it may feel challenging, and it is worth it. It is so worth it, because it helps the communication, so that you can have that communication that often we can't have because of CJIS or because of HIPAA or whatever you're obligated to. So if that's something you're interested in doing, start there.
Yeah, and we have a dashboard that pulls all that data into one location, so we can look at that and sort by how much contacts they've had with law enforcement, how much hospitalizations. We also use some software that tracks people when they're going to the emergency department. So it tracks our clients and people we're screening. So in the morning, we're going through our 9 a.m. We're seeing, so-and-so showed up at the ED last night. And so we circle back and try to find them and figure out what's going on. I think a good case example, just something I was dealing with earlier, consulting on, is an individual who's in and out of jail, both Springfield and Lane County Jail. Serious addiction to fentanyl, major depression. His brother had died of an overdose 2 years prior, just family history. His other brother's addicted, and mom keeps reaching out to us. But he'd never interacted with any other systems, doesn't want anything to do with clinics or people of any kind of clinical settings. So we just built rapport with him while he's in jail, keep reinforcing that we're here to help him out. And then when he got out of jail, he overdosed and almost died, but his friend used Narcan, revived him, and mom called us the next morning and said, can you guys come out and check him out? And so 3 of us went out that morning and went and checked on him. He was basically detoxing in his room and wouldn't really budge, but we just kept encouraging him to get up, so we get him some basic food, some basic connections, eventually convinced him to go to a MAT clinic and get buprenorphine. And that day was good, and then 2 days later he stopped the buprenorphine, went back to the fentanyl, and some systems would just give up and be like, whatever, he's not ready. We just would keep showing up and just keep showing, connecting with him. And so, as of today, he's still detoxing. It isn't like a miracle case, but we're there helping him. We brought him Narcan, we bring him food, and we've got all the connections and readiness. So we're 100% voluntary, so that's one thing that's unique, is that we don't push the services, we just make them available. And when people come to us, like this individual, we can just go full service. So we kind of swarm people with resources when they're ready, and we back off when they're not ready, and we just kind of use that as a test to see how we can help them. I think lastly is just, I mentioned in another setting that we kind of reinvent ourselves every Monday, because the problems we're interfacing with are more complex and more challenging than anything that I've ever seen in my career. The level of fentanyl, methamphetamine, and the purity and the affordability. Like the individual I just mentioned, he gets high off $10 and it lasts him all week, and he's super high every day. And it's just pretty challenging as a system to interface. What we're offering him to counter that is amazing clinical services, but for him, that other alternative is better most days. But then when he's ready, and we have other good, probably more successful stories when people are ready and actually everything dials in. But I kind of wanted to show what it's like kind of on a day-to-day for us. Lastly, we have 2 vehicles, so we're just constantly crisscrossing town. We do inreach to the state hospital, Department of Corrections, and can span about a 100-mile radius to go find people if we had to, but we try to stay within the county for the most part. And I go on, but and we've, without the Impacts Grant, this program wouldn't exist. So we serve up to 20 or 30 fully enrolled clients and about 20 screening, which is really kind of a unique piece, is that people can verbally consent to our screening, which is light case management and engagement, which really in our system and clinics around don't offer that. It's kind of all or nothing. So yeah, it's pretty good.
We view it as courting. We're courting people so that hopefully they will want the full package. So that's the wonderful thing about one of the wonderful things about the Impacts Grant is having the ability to not have to focus specifically on only those folks who are willing and able to enroll in your services, is that you can really build those relationships so that either they will enroll with us or they will enroll somewhere in the community. We don't have you have to come to Lane County. We will take you to any service that feels like it'll meet your needs. And so, again, importance of working with your community partners.
These are some really amazing programs. Really kind of encouraging to hear all this stuff. And I'll attest, I like maps. And so Lane County has some bonkers geography. So it's absolutely crazy. So, but I'm Adam Goggins. I'm the program manager for Deschutes County Crisis Services. And we also have?
I'm Nicole Von Leven. I'm our jail diversion supervisor who oversees the Impacts Grant.
Yeah, and so thank you all for having us today. Wanted to talk a little bit about our program and how Impacts has really changed the way that we function and how we do business. So Impacts has really helped us and brought us together by essentially allowing our Deschutes County Stabilization Center to go 24/7. So we have been in 24/7 continuous operation since October of 2020. And during that time, we've really been able to serve the community in really kind of profound ways. Especially during the middle of the pandemic, there were all kinds of wild things that happened that we were able to be there and to be supports for. At one point, if it was 1 in the morning, you couldn't go to Walmart because Walmart was shut down. You couldn't go to Denny's because Denny's was shut down. You couldn't go to 7-Eleven because that was shut down. So it was us and it was the hospital. And you couldn't go to the hospital because COVID was going on. And so there really weren't, any options related to that. And so there were times that we were able to support individuals just out in the community who really needed our support. We have a specific group of folks that we end up targeting through the Impacts Grant. They've had 4 law enforcement contacts or emergency department visits. We have worked very closely with our law enforcement partners in Deschutes County to attain the list of individuals, and we'll specifically wrap around those people and provide them services. And Nicole can kind of talk a little bit more about that, but a lot of what we do, generally speaking, is we try to provide crisis services as accessible as possible to these individuals. We had a traveler come in at one point, and she was like, "Man, people are just walking in off the street. This is like 7-Eleven here." And I'm like, hell yeah, that's exactly how it should be. It should be as easy to get crisis services as it is to go to 7-Eleven. Like, that's exactly how it should be. And through the Impacts Grant, through just kind of the amazing programs that we've had, we've been able to do that for the people of Deschutes County. And it has been able to support these high utilizing individuals who have historically, you're talking about they burned all the bridges in the community. They are no longer, they're pretty ambivalent about engaging in treatment or, whatever. It doesn't really matter. We'll meet them where they're at when they're ready to meet with us. There's a philosophy that we operate under called coming from a place of yes. We always try to say yes to an individual whenever they come to us. And it doesn't mean that we're a doormat. It doesn't mean like, hey, buy me a house. It's like, well, okay, hold on. We can help you with something else. We can't necessarily buy you a house. But that's a really a real strong philosophy that helps to drive our program. And so we don't make a very strong distinction between substance abuse, mental health concerns, houseless concerns, anything. If they come to us, they came to the right place. And so we will help them to get to the next place if they need to. But we're always a good starting spot for people. And it's really showed in a lot of different ways as people are able to access our services at all hours of the night. Since we've opened, we've had close to 6,000 distinct walk-ins. 19% of those were law enforcement drop-offs, so they had some kind of engagement or encounter in the community, and they were like, no, this person needs some help, and instead of taking them to jail, instead of taking them to the hospital or doing something like that, they brought them to us so that we could actually try to work with them on getting them connected with services. About 17% of them were emergency department diversions, so we're directly diverting from the emergency department during the middle of the COVID epidemic. All of these things are stuff that we've been able to provide. And so, those are things that we're really working on trying to be, again, as accessible as possible, especially when it relates to these high utilizers, especially when it relates to folks who haven't necessarily been well served by traditional modalities, we'll say. And so we're trying to be as creative and as cooperative and collaborative as we can to wrap around these individuals. And we have this station that's been built here to help us to provide support for them. About 10% of our walk-ins come in at night. So it's not our highest volume night, but it is our highest value night because the service that it enables us to provide is 23-hour respite. So we are able to keep folks in our respite unit for up to 23 hours. So that helps them to divert from the emergency room, that helps to divert from higher levels of care, that helps to, if someone's intoxicated, it gives them time to kind of chill out a little bit before we send them back out into the wide open and stuff like that, and has served to be a huge boon for our project overall. And people generally don't stay anywhere near that. They can stay up to 23 hours, but the average length of stay is about 10.8 hours. And so those are the general programs that we have related to the Stabilization Center that we've kind of built as an infrastructure to support this core impacts group, but in doing so has supported the broader community as well and has had a tremendous impact. Nicole's team is the forensic diversion team, which specifically works with the impacts clients and identified folks that we've identified through the grant, and she can kind of attest to some of the, I keep saying impacts, the impacts of the impacts grant and how that has impacted us impactfully. So,
well done with the triple.
Yeah, that's good. That's good branding.
He can do that all day long. Another piece to what Adam was talking about, like we added positions to make that center 24/7, and I think the accessibility to care is really what that speaks to for this target population, because often these clients that we've identified and that we're working with, they have law enforcement contact in the middle of the night. Well, they can go to the ER or the jail, and historically my team that works 7 to 3:30, except for myself, who works later, they are not able to get to the jail by 5 a.m. upon release time, or the middle of the night when the ED discharges them after they clear. So then they're back in the community and in the wind and have law enforcement contact, and we felt like we're just chasing them around. Because a lot of the folks that we found that were in this list were the folks that we were already working with or trying to work with, and that would come into crisis occasionally, or we'd get referrals from different areas. But this availability to have somewhere for these people to go and stay in the middle of the night has allowed like wraparound services to really become more robust and more accessible. Yeah, so our mighty team of 3 peer support specialists, but one of the peer supports is also a QMHA. They do a lot of pre-treatment services and work with people. I loved the term courting. I'm going to take that back because I literally feel like we just go out and throw whatever might work at them.
Like, hey girl, what's up?
Yeah, like, okay, we will pick you up and take you to your PO. We will take you to urgent care. You don't want treatment yet? That's fine. We will get you to what's most important to you, and we will do that in a harm reduction approach in order to continue supporting your goals, while also encouraging treatment using motivational interviewing to get these folks to a place of stability, whatever that looks like for them. And some of those folks, like they said, are not fully engaged in services. And some of them get fully engaged and then they go back to jail and then they get fully engaged again, and we do this dance for years. But I do have a few different cases. One is sort of along the lines of like, we are just going to keep showing up and keep doing what we can to get you to that point. We have an individual who from 2018 to 2022 had been arrested a total of 18 times, or 28 times. And we have seen a decrease significantly over those years. We started working with this individual in the later part of 2022. They have not been arrested since May of 2022 now, and continue to use pretty actively. Don't want treatment, not engaged in services, but will show up with our team because we are doing things like supporting getting access to a shower, food boxes, taking them to the needle exchange, because all of these things are going to promote their health and safety, and they have now developed trust with the system they have historically had no trust with. I used to work on our mobile crisis team and worked with this individual in the setting of like law enforcement calling me out, see if they can go to the hospital. Yeah. And this person did not like us. Very much would be like, I don't want to talk to them, they can go away, and then they'd always end up in jail, and we felt pretty hopeless about what we could do to build trust with this individual. So I'm pretty proud of that case in the sense that we are starting to build some trust and hopefully can get this person connected to what stability will look like for them. And then another case is one where we were very highly concerned. We've worked with this person on and off for years, and they are an impacts identified client and also had risen to the level of threat assessment. And our community partners, luckily, are really involved and will bring things to behavioral health. And kind of through a really creative plan together, because we were able to collaborate and talk about this and had a ton of releases on file too, but the active threat was more important anyways, HIPAA-wise. And our hospital, our jail, probation and parole, all put significant funding towards getting this person a plan to get them through the weekend, and our stabilization center staff kind of got creative with our own admissions and discharges in our respite unit to keep this person from using so that they could get to treatment on Monday. They ended up having to stay Monday too. They didn't get there till Tuesday, but they were released from jail on Friday and got to treatment on Tuesday. And without the help of our local hospital to get lab work pushed through into that treatment facility, without the jail not releasing the person at 5 a.m. and also getting their lab work done, allowing the hospital to come in and do that lab work, and without probation and parole kind of bringing this concern to our awareness, we wouldn't have had that. And I think we had already had pretty firm established community partnerships, but by getting the data from law enforcement partners, from like making sure that we're all on the same page with what our goal and mission is to reduce those contacts, to reduce those individuals ending up in jail and getting them access to treatment, we've been able to come up with some really creative solutions and things that have really helped supported these individuals. That client is very happy now with where they're at. They're still in treatment. It has been weeks. I don't like to say those things out loud ever. I'm a little bit superstitious. But they are also like looking to now work where they are and receiving treatment. That's a long-term goal of theirs, and that is not something we'd ever seen before.
And that one had a big safety element as well. Like
Yeah.
there were significant concerns for public safety during that time. The hospital was like getting armed guards and other kinds of things because of this. And this is something that we were able to facilitate as a part of this process, which wouldn't have otherwise existed.
Yeah, and this person clearly identifies, like, when we took them to treatment on that Tuesday morning, they said, you know, without the stabilization center and all of these people being there, I would have used, and I would have ended up back in jail. PO would have either written a warrant or detained them, and then, or they would have done something to end up back in jail. So they identified that themselves, which was kind of spoke to the impact of, like, how, I'm not going to say it too many times, how the funding from impacts has helped the stabilization center and crisis services in conjunction with the wraparound services our jail diversion team already does. But being able to have that, like, target audience of who needs what and really tailoring it to individualized specific needs has been really, has dramatically shifted, I think, the way we do things, and kind of the way our jail diversion team operates is like we used to, well, I have a list that I try to update every week. I was getting a little behind before. Kelly knows because she works with me, about, like, what to do with with these identified clients when they come in, because they're all needing different things. Like, we haven't seen this person in weeks, please admit them to respite if you can. This person has really poor boundaries and got aggressive last time they were here. Maybe do a risk assessment in this detail with asking these specific things, because I know a lot more about that client than, like, just our crisis clinician does at night. So trying to have that communication be as updated and as thorough as possible for these clients that are really at high risk for overall utilizing the system in ways that they don't necessarily need or benefit them. It's not really client-driven care. So, anything else? All right.
Thank you all.
Thank you. And last but not least, Union County.
Good afternoon, everybody. My name is Corey Escobar, and I am the Impacts Coordinator for Union County. The Impacts team in Union County is myself. We have a case manager, we have a peer, and then we also have an employment specialist. We started running out Impacts, I would say, around 2020. With the overall goal to help reduce recidivism with some of these individuals in this target population, this 4 or more jail contacts, emergency services contacts. The first order of business that we had was really just connecting with all of the community partners and getting weekly, monthly reports of individuals that would fit in this target population. One of these reports, and this was something that our organization at Center for Human Development hasn't really done before, was actually obtaining what law enforcement, I believe, calls a call to service report. So every month, the lieutenant that we are connected with actually emails us a report of any contact they had, and I believe the code they use is a 1096, which is, I think, suspected mental health issues. We obtain that. We take a look at the names, the amount of contacts they had, what the descriptions about the contact is according to the dispatchers, and we make the outreach plan for these individuals to see if they would like to come in and not necessarily even engage, but just like to know more about the services, not only just at the Center for Human Development, but in Union County as well. This worked really well up into a point that we reached really shortly, where some of these individuals don't have contact information at hand. So we just devised another plan where our peer every other week actually goes on a ride-along with law enforcement to connect with these individuals with these calls. This is where the team really started to see some of the success with impacts. For some of these individuals in the target population, when they see a police officer roll up, somebody gets out, they start having a discussion. We have, our peer that's also in the rig, talk with them saying, hey, I know it can be really hard because I've been exactly, where you're at. If you're ever, want to talk more to see what we can do for you, here's my business card, give me a call. After this, we actually started seeing, like I said, some really good success with the impacts team that we have in Union County. One of the big successes, which actually happened really early during our impacts team, was we had one individual that was on this calls to service list, I would say maybe 10 to 15 times a month. So they were utilizing hours upon hours of dispatch time, law enforcement time, especially because the place of residence she was at was about half an hour from where, our dispatch currently is, where the law enforcement vehicles would be. A lot of the descriptions on the calls to service would be something like she was being very combative toward her neighbors and also combative toward law enforcement. After we got this report, we devised an outreach plan to just contact her on about a weekly basis or so, just to check in to see how things are going. At first, she was pretty adamant about obtaining any sort of service that we have at CHD. But after a couple of weeks, so I would say about 6 or 7 outreach contacts, she messaged our peers saying, okay, I'm in. What kind of services does the Center for Human Development have? So we finally got her in, and I would say after 3 months or so, we noticed that she wasn't showing up on the calls to service report, so that got reduced drastically. And she wasn't showing up in the emergency department reports for altered mental status at all. Our community partners initially thought IMPACTS was just going to be kind of brutally honest, going to be another acronym they're going to forget. But it actually became more of like a verb that the community partners now use. So in MDT meetings, if we have a problem person, they'll just state, can we IMPACTS them? Can we get a small team to go over to where they're at and provide this consistent outreach to them to see, and I think it's been repeated here, not just if they can come into services, but just be interested in the services around the county. It doesn't have to be just us. It can be our hospital services. It can be, DHS additional services. Just getting them connected with the resources that they would benefit from if they were to engage. Consistent outreach was our main goal with IMPACTS. And one of the other ones that we really wanted to do was healthcare navigation. For those individuals that are in the jail for more than, from what I've seen, about 20, 30 days or so, Oregon Health Plan turns off during that time. And a lot of individuals do not know how to navigate that and get that turned on. So another kind of program that we did at CHD was that a couple of us became OHP assisters, so we can actually assist with turning on somebody's OHP. This became a huge way to outreach individuals, especially when we have the jail reinforcing us. If someone's getting out on a Friday morning, they can easily state, hey, you're getting out, go to CHD. They have somebody there from 8 to noon that if you walk in, they can get your OHP turned on, or they can help getting your OHP turned on. Sometimes it's not as easy as I want it to be. But that has been one of the biggest kind of outreach and engagement activities that we have. Somebody can just walk in saying, hey, I lost my OHP, I need help turning it on. Cool, we have a walk-in program for that. Because of IMPACTS, our number of assisters has increased from 2 to 4. So now we can provide this very nice service for the clients that just walk in. The third and final kind of big service we really wanted to provide with IMPACTS was rapid employment assistance for those individuals that really just needed that extra boost if employment was an issue. We already have a supported employment program at the Center for Human Development, but this allowed them to really just propel to the top of the wait list for these individuals. And we actually have an employment specialist that has time allocated and experience working with those individuals that may have employment barriers because of background checks or because of past convictions. We work with our jail, P&P, the hospital, and local agencies of law enforcement to really help provide this overall this outreach. It's really nice to see this very small team grow from something we just started 2 years ago to kind of this really fast engagement and outreach style team where we custom make plans for the individuals based upon the client's needs. I think that kind of sums up about what we do at Union County.
Awesome. Thank you all for sharing. Really, really appreciate the time, the effort. The goals of this project are the same across each site. but the approaches are a little bit different. And I heard a lot of common themes threaded throughout, and I'm lucky that I get to talk to grantees regularly. Some things that I heard, just increasing the local capacity in your regions and your areas to be able to address need. You have some other resources, but this is a resource that you're able to apply more flexibly. Partnerships, huge theme across the board with really diverse representation, and your teams that are in the community, multidisciplinary. We heard peers mentioned, care coordinators, outreach into the community, in-reach into the jail, in-reach into the state hospital. So really great approaches. I have some questions prepared, but I really want to take a moment and turn to the audience. I'm curious to know if anybody has questions that they would like to pose to the panel. Seeing head shakes. I see one right here. Avery will go ahead and bring you the microphone in 1 second. Thank you, Avery.
So a question for kind of all of you, but to start out with, I'm really bad with names, so Deschutes County. You guys said that you have had, where instead of law enforcement bringing somebody to the jail, they've brought them to you guys. What does that look like? What if that individual doesn't want to go there? Is it basically it comes down to, okay, you can go with these guys or you can go to jail, or can you hold them without them wanting to go there, or?
No, that's an excellent question. No, we are a completely voluntary facility, and when we opened up, we did a lot of briefings with the officers and stuff like that, and it was essentially, you can give the individual a choice. Do you want to go to jail or do you want to go to the stabilization center? And whenever they go to the stabilization center, they'll still cite them potentially, depending on what the crime is, but they'll at least won't get caught in the jail system and then potentially get caught in the aid and assist system and then get caught up in this whole thing that could, last for a really long period of time. But generally speaking, our officers are, we going back to the whole partnership thing, we have an excellent partnership with all of our law enforcement partners in our community, and they are very wonderful and they speak very highly of us. And they're good salesmen in that sense. And so they can be like, hey man, we'll come here, you get you some noodles, get you a place to rest, get you some other thing, and so they're really good about selling it in that sense. And so we don't have the ability to detain anyone, nor would we want that. Mm-hmm. But it's kind of a carrot approach to trying to solicit that.
Can I add to that?
Yeah.
Okay. And we don't have the ability to detain, but all of our QMHPs on staff do become directors designees, so they do have the ability, if someone is at risk to themselves or others, if law enforcement brought someone in, their crisis changed, their presentation changed, we can put a director's hold to get them to the hospital. So we can provide the next level of care if they're needing it, rather than having to call in like just one person who could do that service. All of our QMHPs get trained to do that. As well as we have an individual who came to the center from law enforcement. They got cited for theft because the PO wanted them to, but then they got connected to my team. They are an Impacts client as well. And we were able to go to court with them then the next week because they got cited instead of being in jail. Yeah. They were able to get connected to meds, get really engaged in services, and we were able to go advocate for them in court, whereas if they had gone to jail, been booked and released during COVID, we would have never known. So the fact that our law enforcement partners do bring people there and either cite and release or in lieu of citation has been really helpful.
And it is a good thing to note and to be very clear with the officers as well, is that we are not an involuntary facility too. So if you leave them here, they have the ability to leave 2 minutes after you leave. And so that's happened before too. And so they just have to kind of be aware of that, kind of informed consent in that way, but yeah.
Okay. So I asked this because I work in corrections in Crick County, and we have a lot of individuals who don't necessarily need to be in jail, but they were causing such a disturbance in the community and that's all we have over there. And that's just, it's not a good place for them, and it's very frustrating. So this program's very interesting. But my other question was kind of for everybody. I heard from a couple, what is your, basically your criteria for who you take in? A lot of you mentioned like 3 to 6 referrals a month, or the ladies from Lincoln County, yeah. You guys said 6 referrals a month. What is referral? What criteria do you have to meet? I know that for law enforcement interactions or emergency personnel, but is there something else there? Do you have to have mental health on board also, or?
So in regards to, in Lincoln County, I actually have the FUSE program, which is Frigate Users of Services, and that has that for ED visits and for you know, jail visits in the last 12 months. And so that's actually a different program but that peer works with Jamel, and they roll together a lot of times. And but for us in Lincoln County, it's the criteria is whether or not the police officer, one of the things is whether or not the police officer is willing to take the time to call us. And so we're a little different. They do not cite the person. If you call leads, then essentially the person has to be, it's voluntary. And the first time when they call us and they say, you know, I have so-and-so and you know, it's midnight and they're in their pajamas and it's 18 degrees and they won't stay out of the laundromat. And he obviously has, you know, some mental health issues. I ask, you know, is he willing to talk to me? And a lot of times the police officers will forget that, and they'll go back and say, and then he'll come back and say, yeah, Lori, he's willing. I say, I'll be there as soon as I can. Give me 20 minutes to get there. And so if they go with me, or the police officer and I take them somewhere, a lot of times in the middle of the night, I'll be honest with you, if I'm alone, the police officer transports them, I don't. You know, that at that point, that the police officer's turning them over to us, and they're not being cited, and but they're being given an opportunity of working with a navigator, and that's the opportunity that they're given. So we don't have they have to meet the 4 of this or the 5 of that. It's whether or not the person wants to work with us. And a lot of times the police officers will tell us, you know, this is our 4th time in the last 72 hours that we've had contact with them, Lori. This is you know, I mean, this is a very frequent person, and they'll usually not do it on the 1st or 2nd. They usually wait until you know, they've seen him quite a few times, and then they give us a call. But it's more about, it's a diversion from putting them in the jail. And because 90% of the time, the issues are not per se criminal issues, they're social determinants of health issues.
I'm not a grantee, but I'd like to respond to that as well and just say there's so many different approaches that folks are using, and we heard from Sue about using data to then have a list generated. Corey also mentioned having a list of calls to service. So some folks have a generated list where they're trying to go out and find people in the community that they know are high utilizers based on a criteria that they have set for their community. And we also have some folks who have partnerships like the LEADS program where they're going out, and it's just a different approach. So each community has been able to really define what is a high utilizer. Underlying everything, every program is mental health, substance use disorder. So that's common thread between all the impacts grantees.
But it doesn't have to be both. It doesn't have to be mental health and drug use. It could be just drug use that they're struggling with. And
I think in our system too, we even try to open the door to like intellectual developmental disabilities, dementia, neurocognitive issues. Anytime anyone has any kind of crisis, it qualifies so as to kind of keep the doors broad and as open as possible. And so, yeah.
Yeah, I've noticed in our community, a lot of intellectual and development disabilities that they don't get resources through the normal IADD systems.
Yeah.
And usually because they were underdiagnosed as youth and now they're in their 20s or 30s and they don't really have a really fighting chance to get back into those systems, but they have all those issues still compounded by typically drug use and mental health. The other one is traumatic brain injuries. I mean, probably 30 to 40% of people we're seeing have TBI, usually from violence kind of related stuff or like major accidents. And then another smaller population that we see, but it's coming up a little more frequently, is veterans that are completely off the grid. They don't want anything to do with the VA, and they meet the criteria at the baseline, but still need help. So we have a connection to our veteran services, and we start working within their systems so they can run information gathering deep into the VA kind of systems and seeing where they served, with their criteria for if they have benefits there, and then we can kind of work collaboratively to get them care and help. So I'm finding there's all these subpopulations within, populations. And for us, it's basically what they're describing. It's behavioral health disorder, broadly interpreted by the DSM, especially anything in that book passes muster for us. With the exception of maybe they're just, mildly like adjustment disorder, don't really need much. We'd refer them out. We'd still help them to get them on their way. I think historically our team was really focused on the people that were the most severe, and that's still part of our kind of cornerstone, but we're trying to now to see what else is out there. And surprisingly, there's there's populations amongst populations that aren't just severe, but they have a whole host of other problems. And addictions is, I think at this point, everybody on our team being served has mental health and addiction, and they're unhoused. And that's 30-ish people right now.
Avery's going to come right over with the microphone.
Maybe this can just open up for just other comments or observations that can add to the quality of this amazing panel and all the great work that each one of you are doing in the county and individually in your own careers. And thank you so much for meeting people where they're at. I hear radical compassion going on and hope bringing. And so one of the things that I do share with working with some people that forget to have hope and lost it, and I say we help hold that hope until you remember to have hope and not giving up on people, and because they're somebody's loved one. And so this Impacts grant helps us as a community be hope bringers to the people that kind of get forgotten, and everybody is worthy to be seen. And so what's very different with this Impacts program, after being in nonprofit arena and systems and agencies throughout many years, there's this pressure to perform with outcomes and a certain microcosm of what you serve for a certain grant. And so sometimes people will back up off of maybe bringing services to individuals because they're not proving that there's some positive outcomes. And I forgot your name, right? Jeremy. I appreciated a little bit of what you brought. It's amazing to see successes and see the whole picture of a success, but sometimes just success is that the person's engaging with you, and that we make space for that too in our funding, and that can be a success too. And that outcomes in this Impacts program, there's room for growth and breathing and meeting individually and being innovative with that. And I just really am, it's a change that's happening. It's a culture change on how we're looking at communities and making a difference in people's lives and providing meaningful impacts with behavioral health and substance use, and just the holistic person with somebody who's just really lost hope. and the symptoms of what that looks like. So I'm really grateful to hear about all the good work that the people are doing here, and that our policies are really working, and that we want something different, and we're doing it. So thank you, and I celebrate everybody here for doing it, and thank you, everybody.
I just want to make a quick comment. You know, one of the things that I've worked on a lot of different programs, and a lot of the grant-funded programs are quantitatively driven. So, you know, meet this metric or else. So I think the impacts grant's been done really well with us. Is there's quantitative and qualitative kind of overall goals, but the goals are really clear about just trying to serve people. And for me, just personally, it's kind of brought my love back to the work, and it's also given me an ability to teach my staff. And again, I'm from Eugene, so it's going to sound hippie, but it really is like a lot of love on our team. And as complex as we're presenting these cases, it's also the most fun I've ever had in my career, because we can give people access, like the individual I mentioned earlier. We got him from phone call to the MAC clinic. It was less than 48 hours, and we were there within 24 hours of the first call, like, you know, it was evening then to morning. So historical systems, at least all the ones I worked in, never worked that fast. It's get in the queue and wait and wait and wait and wait, go on a wait list. Hopefully you don't die on a wait list, and then wait and wait, and then maybe get care. Whereas this rapid piece, so it feels like with my little business cards, they're kind of like Willy Wonka golden tickets. And I've talked to officers like, here it is, this is a golden ticket. When you find that person you know, give them this, and they're going to get access. We never had that before. So like I said, just love and respect and compassion is sort of odd as it sounds in the context of forensic mental health, really does apply to this. And the people it draws in, our team is so interesting that I call us a pirate ship kind of within mental health, because we all come, I mean, people who have been in prison before, people in recovery, you know, people that have gone just through academia. There's this amazing hodgepodge of folks, because it takes unique people who want to go do this every day. And then lastly, I think, is just having the ability to work with law enforcement and see the work through their eyes. Again, there's more love and compassion for the officers and deputies that we work with, that when people come and talk to me about their different views and things, I really am able to champion from a perspective that I'm seeing every day working with law enforcement. And what I'm seeing is so much compassion. Some of the officers are more social worker than a social worker that I've worked with, because I'm seeing them firsthand go back. They know all these people by name. They know exactly where they live in the streets. All they want to do is get them help. I've never seen a single officer or deputy do anything like sideways. It's always from that point of compassion. And so those are just kind of little highlights, but it speaks to what you're talking about. It's just like, I don't know, it's just really cool. I just feel really grateful that I get this opportunity, because it's revitalized my career. As I head out, 15 years, I'll be retired. It's nice to kind of ease into this and have this experience, because other settings and places I've worked at, it isn't the case. You just watch people dwindle and go to prison.
Well, I think this morning when the judge was talking about what the gaps were, I think I was hearing people say more program gaps. But Jamel and I were talking at lunch about, or after she presented, the gaps that I see are, historically I've been in the field since 1994, 30 years. A person came in, they did an assessment, and their PO looks at you the following week and says, well, why aren't they clean and sober? Well, because they've been using heroin for 20 years, and it doesn't happen in 5 days. Well, then they're going to go back to jail, or that kind of stuff. And one of the things that this allows us to do is it allows us to not have those archaic systems and that archaic thought process that just makes me want to just scream at these people at times. And it's like, this didn't happen in a week. You can't get this isn't going to. We're just lucky they walked in the door and said hello, and we sat down with them and we filled out 3 pages of paperwork with them. That was a success today. And you're going to put them back in jail. And so I'm not the probation officer's friend this week, I'll be honest with you guys. And because I have this kind of harm reduction more, working with them where they're at. The fact that you have to, sometimes it takes a month or 2 to actually develop relationships with people, and for them to actually come in and actually sit down with you and talk about what's really going on. It doesn't happen just because you were sentenced last Friday. And so I think one of the things that Impacts allows us to do is not have that kind of oversight of why aren't you doing this why aren't these clients clean and sober? You know, I've been doing that for 30 years. It's Jamel's meeting them where they're at, you know, in a motel room, in the streets, in the, and you know, on the side of the road. I mean, these kind of places, and they, you know, it might only be for 15 minutes the first time. It might be a half an hour the next time. It might be an hour the next time, and she's developing long-term relationships, and we don't have that kind of archaic oversight that isn't helping our clients.
I also just wanted to plug that, you know, it was piggybacking what Jeremy said, that our jail captain is phenomenal. He plugs us more than anybody else. You ask him about FIT, and he is the choir. He's singing. It's been amazing to have these relationships. And same thing with our judges. Our judges come and meet with us quarterly. We sit down together. We break bread. We talk about what our challenges are. It doesn't mean that it's always smooth, but we work it out. And it started from our impacts, and it has flowed into our civil commitment conversations. It's flowed into our aid and assist conversations, because all of these programs overlap each other. Jeremy's team is sort of like the little sweep. They come around to everybody. They can, which is wonderful to have that ability to sort of, where other systems are very rigid, and this is, you know, you're in or you're out, and that's it. FIT can come right behind and be like, hey man, I got a sandwich for you, and a sleeping bag, and a, you know, a backpack, and a, you know, oh, you need a ride to the mission? Great, let's do it. You know, whatever needs to happen. And so it's been really nice to have all of our systems work together to align, and when there is a hiccup, we can sit down together and work it out. We're all really, I said, very client-centered in terms of, you know, making sure that, because I mean, we look at it, we approach it definitely from different perspectives, and what we see, I mean, in the jail, they see a lot of different things than what we see, and behaviors that we don't have to deal with because we're perceived differently. And so just understanding, really trying to create a sense of understanding for each other, and mutual respect for the work, and understanding that everybody has an important part in creating safety for the folks that we are serving. And that's probably one of my favorite things about the Impacts program, is it really has brought our community together that way.
We're from Lane County Jail, and when we see a release to the victim, it's a relief for us, because we know that person, we don't want them to go to the street and not get the help. And so being able to see on the release list, oh, they're going, we have to do a warm handoff, get these people to the lobby, to the FIT team, because they're going to help them with resources further. Whether they walk away from your team in the lobby or not, we always really hope and try and sell them as deputies, you're going with these guys, they can help you. Listen to them, even if you know, try to listen to them, because this wasn't fun for any of us. You know, you've been here a long time, you need help, they want to help you. And so having them, I didn't realize it was grant funded, just to become a thing in our jail that, oh, thank goodness, the FIT team can take these guys and get them help when we're releasing them, so.
Yes, I love that compassion came up. That's something that I get to hear from all the grantees, and having a whole panel of you together, it's just, you know, totally overpowering with that feeling. And other things I heard, non-judgmental approaches, being accessible. So we hear low barrier often, but just having these services accessible in the community. And I also wanted to shout out to the Criminal Justice Commission, because something I hear from all of you in my conversations one-on-one is that they've been flexible when adjustments are needed. The timing of this program was so challenging, 2020. Adjustments were needed, and CJC, I just commend you for your flexibility, and have heard that so much from the grantees as well. I think I saw a question up front, potentially.
Yeah, I'm not from Eugene, but I'm still going to get involved with the Love Fest. I'm Tri-Cities, Washington. And just a comment, you know, you guys have, hearing you all speak has validated what I've been saying for years, and it is all about me, just kidding. But it really is people that make programs, not vice versa. You could have the most well-designed program and not have the right people in it, and you're not going to get results. You can get an average designed program and have exceptional people, and you're going to get exceptional results. And that's what I've heard from you, is that you guys are taking a non-traditional approach. You've talked about it changing your career, the compassion, and the passion that you feel, and I think that all of you feel towards your clients. And so I want to applaud all of you for the work you do and the people that you've hired, because that's really what makes the difference. So thank you.
Well,
Well, I just wanted to second that. Getting to work with all of you, it's been wonderful hearing what all of you do. Something that really piqued my interest was a comment that one of you said. And just with provider burnout and provider retention being such a thing right now, I'm curious as to how many of you feel like that some of this flexibility and having this funding has either helped reduce some of the burnout that you might be feeling, or that has improved kind of your experiences with your profession.
I want to just talk about the flexibility. We've had a couple of cases in the CJC since I have started our grant, and the ability to call somebody and not feel afraid to say, hey, you know, this is what's happening. We just lost 3 staff. We have 3 people that were done, burnt, left. We want to flip this around. We've looked at this, or we tried this. It's not working. The amount of flexibility that we've had to do that so that we could have really solid programming has been amazing. And so super grateful for having the capacity to do that, because it's helped us. I mean, we have probably shifted our staffing pattern, I'm going to say about a half dozen times since we started this, all for the better, all for, like, you know, figuring out what the nuances that we need to create. What does the staffing balance need to be? Do we need more QMHPs? Do we need more peers? What makes sense in terms of who we're serving and the actual work that we're doing? And you don't get to do that often with funding. You're pretty, you know, this is what you said you'd provide, this is what you need to do, and that hasn't been that way. Creative conversations around looking at things differently, with the bottom line being, how do we better serve this group of folks? Like, we don't care how that looks, or we do care how it looks, and we want it to be efficient and effective for your community, and that's more important than sticking with these sort of rigid guidelines. So that's been super helpful for us to, again, attract, you know, and retain staff that want to do this work. I think to Jeremy's point, all the folks that want to do this work, hiring during COVID, like literally getting that grant, and on June 1st, 2020, people were like, I have no interest in doing direct service with people who are on the street, who could potentially be ill with whatever this stuff is that's going around. No, thank you. And mental health, it just, you know, got progressively harder in that process. So again, having the flexibility to sort of look at things differently and be like, okay, right now, this is what we need. We just need, you know, bodies in the streets. We don't care what that looks like in terms of whether it's a QMHP. We can figure that out in the back with the rest of our programming. But here's what we need out in front. So we did that. And then as things shifted and changed, we were able to look at it differently. So super grateful for that flexibility.
Yeah, I 100% agree on that too, because we face the same challenges too. Like with COVID and stuff like that, it's scary. Like it was, you know, really scary. They shut down the parks. Like they put police tape around parks because they didn't want people riding on swings and stuff like that. And so those are things that like we were facing. And so the appeal, especially for our QMHPs, do you want to work from home and telehealth, or do you want to go out into the streets with people who have poor hygiene and are potentially closed in together and stuff like that? And so that has been kind of a perpetual challenge for us over the past 3 years. And yeah, the flexibility that we've been afforded has been enormously helpful in trying to recruit and retain individuals and trying to make this happen, because it's just unprecedented how difficult it's been to hire. Previous to COVID, you know, we had our mobile crisis team. We'd have 6 applicants per round, 8 applicants per round, and now it's like, well, shoot, we had this position open for 4 months. We haven't had a single applicant. Let's hope the first one comes in, they can breathe, you know, and so that's where the bar is at this point. And so the flexibility that comes with it with staffing has been huge.
Especially with a 24-hour building,
yeah.
And having to have minimum staffing.
Everyone wants
We
to work nights or
changed, nights, swing, weekends, busiest shifts, sometimes the hardest shifts to access any type of care. And we were able to shift our model of staffing so that it made it more stable, and so we were able to keep our employees that worked night shifts because they were working 5/8 on nights, and that's horrible. And some of them preferred 3/12s, or some of them, and so being able to do that rather than sticking to what we were, I think was able to help retain some of those harder to fill positions like QMHPs that could do telehealth. Yeah. And my jail diversion team has had some turnover, but the 2 of our 3 have been there since 2018, 2019, we're doing this work. So that speaks to Jeremy's point of, I think, like the people who are drawn to this, that pirate ship, like get really passionate about the creativity that they get to put forth.
I think one thing I'm noticing too is I feel like it gives us the ability to do quality over quantity in terms of the work we're doing. So clinicians in particular, I found, really love the ability to spend the time looking through the records. So what I noticed with all the clients, they come with so much stigma, even within our community. Oh, that's so-and-so, no way, blah, blah, blah. And so there's a kind of knee-jerk reaction, I think, in like quick-paced fee-for-service settings where you're gonna have to just turn and burn. So you're gonna look at that last assessment, oh yeah, they got 18 diagnoses and 33 differentials, okay, next, and they burn out and they don't show up. Because we're grant funded, we're not fee-for-service focused, I mean, my QMHPs can spend even sometimes up to a couple hours reading all the records, and it has happened a few times where they'll actually get to correct diagnoses, rule stuff out, clean it all up, and give the person a proper, like, quality-focused assessment, and the diagnosis shrinks down to what's really going on. And typically what gets missed with these folks historically is all the historical trauma. I think of one person who's probably one of the most heavy-hitting in our community, and, you know, burned out through all systems, banned from everywhere. And our QMHP spent many hours digging through all the records and found basically, 15 years ago she had been trafficked for a decade. Well, that's why she's reacting to everybody a certain way. And we could go back to partners and say, you know, give her a second chance through this lens. You know, and some people were unwilling and some people were willing, but we can keep the services wrapped around her as much as we can to then hopefully give her a fighting chance the next time she goes back into more traditional systems with a proper diagnosis. We're definitely not a panacea or a miracle team, because all that data was sitting in the record, just nobody had time to read it, you know, the traditional systems. So I just hope these kind of grant-funded programs replicate, because, you know, we could evaporate without funding, and then, you know, nobody that I know of in our community would serve at least 10 of the 30 people we're serving currently. So there's that piece of, like, these are really becoming critical components of our counties, I think.
Well, thank you all so much. We are at time. We're going to have to wrap up now. We're reconvening with a couple of additional grantees for the final session of the day. So if you had a great time, please come back. The conversation will continue. And let's give a round of applause to our panel today. Thank you all so much.
That's the idea. I think I was the only presenter that sat at our local one. I was like, man, I've been sitting with you all week. I'm going to sit in front of
until we got that first success. Like, everyone's like, oh, okay, wait a second. Like, I think we may, okay, go Janet.